Okay, we are ready to start. Sorry for all the delay in the beginning. Okay, so just a couple of quick announcements for this week. Friday is your first exam for both classes, so it's your first exam. You're probably all freaking out. What's going to happen? Today we're going to do sensory neurophys, learn how we sense the environment. Depending on how much time is left, we'll go into the last little bit, which is the higher brain functions. Then we have one little PowerPoint on immunity. It's not much. We'll try and get to it tomorrow when we finish up the last little bit of neuro. Thursday, we will have a review. I have a Jeopardy, Kahoot type of thing. It's just, what?
Sorry,
oh, okay.
Like
Okay. Yeah, so I mixed them up with like Kahoots and like a Jeopardy style where it just shout out the answer. For physio at least, I can't speak for other courses, but as far as the testing goes, we're not here to trick you guys. We're not here to make you assume something's in the question that's not there. We give you all the information that you need is in the question. For physio, it's going to be a lot of like straightforward. What is this? What does this? What ion is responsible for this? Basic questions, and there are some thinking questions. Stuff we'll get to today. I'll explain, what if you alter this, what's going to happen, and so forth. So it's 50 questions, it's straightforward. And it'll be Friday morning. Yes?
Will the Thursday review also be recorded?
Yeah, and I post the review on Canvas.
Okay.
So you'll get it all. Okay? Yes?
Are the question styles similarly for the review on Thursday?
Yep, they'll be the same. Maybe not the same that question, but similar questions. Yeah, same style, yeah. Again, straightforward, some thinking questions, just to make sure you understand, topics that you can analyze and apply those things. So today we're moving on to sensory. How do we sense our external environment? How do we perceive senses, our sight, vision, hearing, balance, taste, smell? We're going to go through all those and figure out how we do all those things. So some definitions to start off with. There we go. Okay. So a stimulus, just a type of energy. Is it light, sound, vibration, pressure, pain? That is the stimulus. The receptor, what actually receives that input? It's also a transducer. You are all hearing me talk right now. My voice is sending waves through your ear and it bounces off your tympanic membrane, but that's a mechanical force, right? That membrane moving is a mechanical force. We have to convert it into an electrical signal so our brain can interpret what we're doing. That's what these receptors do. They transcode from a mechanical to a chemical or a electrical signal that our brain can then know what to do with. Pathway is just how does it go? Today we'll be going over the visual pathway. So I know that's a little bit hanging point in anatomy a lot. The visual pathway is always a sticking point. We'll go through it step by step, the way that what part of your vision goes where. And then last thing is the interpretation. How does our brain interpret that the signal is doing what it's supposed to do? For balance, okay, we're going to talk about the different structures of the ear. How when you bend certain ways, depending on how that structure moves, will tell you, are you moving forward or backwards? Are we going up or down? So we'll go through all that stuff as we talk. Okay, so we have to talk about these different attributes of a stimulus. The modality, what type is it? Is it pain? Do you have a needle and you're sticking people with it? Are you inducing something? The intensity, the amount of the stimulus, how strong is it? Is it enough of a stimulus to get to threshold so that we can have an active potential and actually do something? The duration, how long is it lasting for? And finally, the location. One of the things we have to know in our body is what is being touched right now. So if I'm holding onto your hand, your brain needs to know that your hand is being touched. What part of your body is being stimulated? So we have to know the location. So let's talk about how our sensory transduction occurs. First of all, we need an adequate stimulus. The stimulus has to be strong enough for you to detect it. If I take a bottle of perfume right now and I spray it over here, that's the stimulus, is the smell. But because the people in the way back it's not strong enough of a stimulus, they won't smell it. But the people up here will, because they're closer to it. So that's what that is talking about. Generator potential, if threshold is met, then you have a generator potential and you have a stimulus occurring, and then whatever else is going on downstream is going to keep going. So you see here in the first part, this potential is not strong enough to get to threshold, and that red dashed line is your threshold line. We talked about the other day about excitatory synapses and inhibitory synapses. So obviously we need enough excitatory synapses to get above threshold to make a full entire generator potential. You can see in C, we have 3 successive potentials that are strong enough to get to threshold. Therefore, we have a stimulus and we have a result from that. Large stimuli are often encoded with higher frequencies of action, and it's called frequency coding. So this is a lot of coding going on because it's frequencies occurring in a short amount of time. The number of receptors that respond to the same stimuli is called population coding. So we have receptors for everything. Our receptors are laid out in our body for certain things. For instance, where does the normal spot that you get your blood drawn when you get a blood draw? Where does it normally get it drawn from? Antecubital spot right here. Conveniently, there's not a lot of pain receptors right here, so it doesn't hurt a lot getting a needle stuck in your arm. But if you got a needle stuck in like your cheek or your hand, your fingertips, there are a lot more sensitive pain receptors there. Therefore, you get more pain when it happens. So therefore, pressing harder on a skin stimulates more of these receptors, and if the more receptors get stimulated, then you get your generator potential. It's strong enough, and you can feel the stimulus, whatever's going on. Okay, so when we're talking about stimuli and our responses to them, we have to talk about our adaptation to them. So there's 2 ways we can respond to a stimuli, a tonic response or a phasic response. The tonic response is constant. That's the important part. And look at the stimuli that are constant, pain and balance. What does that mean? It means if you got a splinter in your hand, in your finger, that pain will constantly be there because you have a foreign body in your finger that shouldn't be there. You don't want pain to go away. That's why they tell you when you go to the dentist and you get numbing medication. What do they say? Don't bite your lip. Because you can't feel pain, you don't know how hard you're biting, and you can cause worse pain that way. Same thing with like diabetics, when they have that peripheral neuropathy and they can't feel the bottom of their feet. They get all these wounds because as they're walking, it's like they can walk all over Legos and don't have any pain with it, but it's still going to cause damage to the skin, damage to the bone, because you can't feel it. So we want pain to be a constant thing that will always tell you what's going on. Balance is the same thing. If your balance is off, you want to know that. If you've ever been on a cruise for a while, you come back on land, your balance is off for a day or two, not a day, but a couple hours. It'll feel off for a little bit, but then it goes away because now you're back on solid ground. So those are tonic responses. You want them there so that you know you're in pain, so the pain doesn't go away. The phasic responses decline over time. You are all wearing clothes right now. Do you feel them? Do you feel that you're wearing clothes right now? No, because you've been wearing them all day. The minute you put them on, you'll feel it, but then after a little bit, you don't even notice you're wearing them because your body just got rid of that stimuli. We don't need it, so we got rid of it. Smell. Okay, that phrase, nose blind. That's a real thing because you are used to that smell all the time, so your brain just kind of forgets that it's a smell. If it changes the smell, any changes in the stimuli, then yes, you'll pick it up. But if there's a smell in a room, someone puts a cologne, after a while, you'll go nose blind, you won't smell it anymore. So those are phasic responses, temperature changes. You first get into a room, it may be a little bit chilly, but you get used to the temperature because the stimuli phases out. It goes away. So those are the different stimuli we have, how long they respond for, and how long they stick around. So as we get to different sensories, we'll talk about this is a tonic response, this is a phasic response. So you know, is that stimuli going to be constantly there, or is it going to go away? So our somatosensory system. Soma means what? And sensory, how do we censor things? So how do we get our senses from the body to our brain so that our brain can encode them and we know what we're feeling and so forth? There are 4 cutaneous modalities that we can feel for with our skin: touch, vibration, pain, and temperature. Those are the only things you can get from your skin. What type of sensation is not there? What? Balance has to do with other things. This is just sensory from the outside environment. Wetness. Okay, we don't have a sensation for being wet. If you put your hand in water, you feel it because the hairs on your skin are moving. Any swimmers here? Okay, during the season you don't shave, and then come the championships, you shave everything off. You don't feel the water for the first time you jump in the water because there's no movement of the hairs to stimulate or simulate movement. We feel wetness when it's cold because that's a temperature response, whether it's cold or hot. That's a temperature response. That's what you're sensing, not the actual wetness. We don't have a sensation for that. Also includes proprioception, which is our position sense. How do you know my finger is up right now versus down? How do I know my arm is up here versus down here? That's proprioception, that's position sense. Where are you in the world? All sensory neurons travel in the CNS. Anyone remember what spinal root does sensory travel down? Is it dorsal or is it ventral? Dorsal. All sensories are dorsal. Always going to be that dorsal nerve. Now, the area of skin. We have our whole entire skin mapped out. They're called dermatomes. And they correlate to the nerve roots that you guys are learning in anatomy. So S1 nerve root has its own little area that it goes to. C5 has its own area that it goes to. And that's how in like neurology you can figure out what's going on with a person. If they have pain in certain areas, using different techniques, you can figure out what nerve root is causing the problem for that patient. Okay, so here are the dermatomes. Remember, evolution. We were not originally a 2-legged creature. We were supposed to be on all 4s. So if you look at the dermatomes when you're on all 4s, and I have another picture, I don't think I put it in this one, but I can send you guys later. Basically, if you get down on all 4s, all the dermatomes line up perfectly because we're supposed to be hunched over. But when we stand up straight, all the leg ones get kind of twisted. That's why on the legs, it's kind of like weird. But upper body, it's pretty easy. The other thing, too, is that when we are developing as a fetus, we are basically one long tube. It's a neural tube. And then basically, these little nubs just branch off. They bud, and that gives you your legs, and this gives you your arm. And the dermatomes just get stretched out. And that's why the dermatomes are where they are. Okay? So those are our dermatomes, and that's how we figure out what parts of the body are getting what sensories. So here's a clinical correlation. Again, we talk about sciatic pain, which is pain going down your leg. But usually it's going to follow a nerve root. So if it's an L5 that's causing the problem, pain is going to be in the back to the buttock, different part of the leg, and so forth. You don't have to know this stuff for the exam. Again, just reinforcing that our dermatomes follow a pattern, and you can test on the skin where they're having pain because they all follow the same roots. So touch sensation is the first thing we're going to talk about. Obviously, we have to deal with the skin. One of the important things about our skin is discriminative touch. That tells us how if you have, it's called two-point discrimination. You have an instrument that has 2 pinpricks on it with a ruler, and you spread the 2 points apart, and it gives you a distance of how many millimeters. And you want to see how many millimeters apart before someone starts sensing that there are 2 pinpricks and not just 1. So the more densely populated those receptors are, the more you'll pick up on certain sensations. So in our skin, again, these are just definitions, we have our Merkel's discs and Meissner's corpuscles. Discs are slowly adapting, best for steady pressure. So you have your hand and you're pushing down on your skin or something like that, you will feel that due to the Merkel's discs that are doing it while you're giving pressure. Your Meissner's corpuscles are rapidly adapting, so they're going to phase out fast. So you're going to have that sensation for a little bit, and then it goes away. And rapid changes in skin contacts. We have Ruffini's endings, touch, but very large receptive fields. So these are better for stretch. These are your stretch receptors. Ruffini's endings are for stretch. Take your skin and just stretch it. Okay, just take your fingers and just pull apart. That's Ruffini's endings that feel that stretch going on. Pacinian corpuscles, again, rapidly adapting. Changes in stimuli, but these are mainly for vibration. So your phone vibrates, goes off. Your Pacinian corpuscles are registering that stimuli of the vibration so that your body knows where you are feeling this vibration. And we have our hair follicles. The important thing with the hair follicle is it has this muscle right there, very, very, very small muscle. And that's what moves. It gives you like goosebumps when your hair sticks up. It's that little muscle that contracts and your hair kind of flexes up to kind of give you like a cat when they get scared or want to fight, their things stick up. Same thing. That's annoying. Okay, so here's the touch sensation. Don't go crazy learning this stuff. Just as an example to show you, your first finger can sense 2 separate points at 2 millimeter distance apart. That's why your fingertips are the best thing to do when you're feeling things out. Feeling for pulses. Okay? Anatomy, you guys have to give injections. You got to know where the arteries are. You have to feel. So the tips of your fingers are very sensitive at feeling pulses. That's why we use it for that. If you look at the calf, about 48 millimeters of distance, so about 5 centimeters on your calf, and then you'll feel that you have 2 separate pinpricks. It takes almost 5 centimeters before you feel 2 pinpricks. But your fingertips, again, what's the function? You need your fingertips to feel things. I don't care about feeling stuff on my calf if I have 2 pricks or none. Okay? Function, what it's supposed to do. Okay, so all these sensory input has to go to a central location in our brain, and we know where it is. It's called the post-central gyrus. What are gyri? The hills or the valleys? The hills. What are the valleys called in the brain? Sulci. So the post-central gyrus is an area of the brain. Post-central, so it's after the central sulcus of the brain. We have a pre-central gyrus and we have a post-central gyrus. The post-central gyrus is all sensory. The pre-central is all motor. So post-central gyrus is always going to be sensory. The pre-central is always going to be motor. And we have this mapped out too. It's called the homunculus. This is the homunculus right here. We know what parts of the brain are responsible for what types of movements. And because we have all this mapped out, we know what blood supply goes to each parts of these brain. So if you have certain symptoms because of a stroke, we know what part of the brain is having the problem. Your leg and your feet. Okay, if you have a stroke and you can't move your leg, we know what artery is doing that. If you have a stroke and you can't move your upper arm, which is all the way Where is it? There. Different blood supply, different type of stroke. So you don't have to know the homunculus, know what the homunculus is for, know the purpose, but I'm not going to test you what is located here. Come on, that's not the purpose of this class. Just know what the homunculus is, and so on and so forth. Temperature sensation, okay? We have cold fibers, which are the most numerous ones, and we have warm fibers. Now, in our bodies, pain and temperature sensation follow the same exact nerve. They go on the same nerve. If you stimulate warmth, that's why if you get too hot, it causes pain. Too cold also causes pain, and you can see that here. Cold pain, cold receptors are warmth receptors, and there's our heat pain. When you get into those temperature ranges, you overload the nerve and it causes more pain as well. So that's why with very, very hot things it hurts, and very, very cold it feels like it's burning as well. They follow the same exact nerve. So again, you don't have to know this again. Just know we have receptors for warmth and cold, and in the extremes it causes pain. Both types are rapidly adapting. So what does that mean? Someone's going to stick around or go away? Go away, because rapidly adapting. Pain sensations. Whenever you see anything that says nociceptors, whatever, noci means pain. So we're talking about pain receptors now. Pain has a very high threshold. Okay, and usually should be silent until a very noxious stimuli presents. The thing is, people have different pain thresholds. Some people do a little bit of activity and like, oh, I'm dying, everything hurts. I'll give you an example. I do work with basketball teams. So I did NBA. I do stress tests on them where they have to run on a treadmill until their heart rate hits a certain rate. The minute you give any type of incline to basketball players, they're like, oh, my legs hurt, I'm done. And they want to stop right away. They don't care, they're done. They feel a little bit of pain, they're like, I'm done. I've also done VO2 max testing, metabolic stuff on hockey players. I do it during their combine, and then also sometimes I do the separate teams. Hockey players just keep going. They don't care about pain. I'm like, okay, we're done. We're not going to do any more. He's like, no, I got more to go. I'm going to keep going. I'm like, your numbers aren't going to change. They are. They're done. He's like, no, I want to go because they want to get the most time on the bike compared to their teammates. It's a competition. They just keep going. So pain sensation. Everyone has different pain thresholds. Some people can deal with a lot of pain. Some people can't. So there's different types of pain. We have superficial, which is just on the body surface. The initial is going to be very sharp, highly localized pain. Think of like splinter in the fingers. Okay. Then you get this delayed response, burning sensation, which obviously going to last longer, and it's delayed due to the unmyelinated nerves. Unmyelinated nerves, we talked about last week, the myelin provides conduction and makes that impulse go fast. When you don't have that myelin, the impulse goes slower. We also have deep pain. Is it hurt inside the belly, inside deep? Does it feel like your muscles are hurting or some sort of visceral pain? Is it deep pain or is it superficial? Again, pain is slowly adapting so that you always perceive it as pain, so you withdraw from that stimuli. Okay, we have reflexes, so if you put your hand on a hot stove, it's going to pull away fast. But you can like mentally, again, if your pain threshold is good, you can mentally just keep your hand on the oven if you want. But as a reflex, our response is always to pull away and get away from that pain. So how do pain meds work? Okay, non-steroidal anti-inflammatory drugs, NSAIDs. Non-steroidal. Steroids by themselves are anti-inflammatory, but you don't want to give steroids all the time, so we give a non-steroidal, which are ibuprofen, Advil, naproxen, those are NSAIDs. Tylenol is not an NSAID, so don't confuse those. So what does it do? Basically, you're reducing the pain sensitizers that are made when you take an NSAID, so your brain doesn't get that perception of pain. So it just blunts the response. so you don't feel it. That's all NSAIDs do. Okay, so we have different ways, again, of describing pain. We have visceral pain, which is coming from the organs. Viscera means the organs. It's a dull, burning sensation, poorly localized. Anyone just have like GERD, acid reflux? It's just a weird sensation in your stomach. You can't really point to any area where it hurts. It's just a general area that kind of feels burning and stuff like that. That's visceral pain. Referred pain occurs because of the afferent fibers from the viscera converge with the spinal cord, dorsal roots, which are sensory. You see how they all combine right there? Because they combine, signals get mismatched. So the area that you think you're having pain in is in a broader area because of this mixing of the visceral nerves and your somatosensory nerves. They all kind of go together. They have to go into the spinal cord to get back up to the brain. So with visceral pain, this is what happens. Look at the heart. What do they always say if you're having chest pain? Where does it radiate to, or where could it radiate to? Left arm and also part of the jaw. Look at the area of the heart. What visceral area is this? Well, that's the esophagus. Here's the heart. It's a big area that's all related to cardiac pain, the heart. It's a big area. Liver and gallbladder, one big area, right upper quadrant. And this is how we know. People come in with right upper quadrant pain. Well, what organs are in that area? Liver, gallbladder. It's got to be one of those that's causing the pain, probably. Right lower quadrant pain, usually going to be your appendix. That's where your appendix is. But it can also move to the other side as well, referred pain on the left side. This is stuff you'll figure out on your physical diagnosis class. Go through all that stuff and figure it out. Okay, any questions on somatosensory and how we receive input from the outside environment with regards to touch? Just make sure you know the definitions, the different structures in the skin and what they do. What do Pacini corpuscles do? What do Meissner's complex do? So forth. Just know what they do. Know what they test for. Okay, moving on to vision now. We have photoreceptors because we're talking about light. Okay, we have to transcode our vision to a chemical or electrical signal so our brain can process the image and we know what we're looking at. Visual field is very highly ordered on the retina, which is the back of the eye. So when you think about vision problems, we have our lens and we have the retina. If your vision's very blurry over the whole thing, it's probably your lens. It's like looking through a dirty window. If your vision looks like it's pixelated and you're dropping pixels, like your different parts of your vision are just black, that's a retina problem. Because the retina kind of gets the full vision, and if you have different parts of the retina that cells just died off, they're not going to do anything, and you have like drop pixels on a TV. If you ever see drop pixels, like little squares that pop up, that's what your vision will look like. That's a retina problem. The processing of vision occurs in the primary visual cortex, which is in the occipital region of the brain. And because of that, we can check for form, color, depth, motion, and distance with our vision. So here's our anatomy of the eye. Okay, we know that light passes through the retina, through the lens, and goes all the way to the back of the eye. And we're going to pick it up from there and figure out how does it get through to our vision, to our brain. We have fluid compartments of the eye. We have our intraocular fluids that keep our eye distended. Okay, when you're born, your eyes are already the full size. That's why babies have like big eyes. Babies, their eyes don't grow anymore. Once we grow, that's it. That's the size of your eye. That's why babies sometimes have big eyes. The thing with the intraocular fluid, know that the canal of Schlemm makes it. Wait a minute, that's not right. Starts it there and it drains into the extraocular veins. That's how we get rid of the intraocular fluid. It's always being constantly flushed, just like our CSF is being constantly made and brought back into our system. Intraocular fluid, our vitreous humor is the same thing. Okay, we'll skip this one. Okay, some principles about our vision. Refraction is the bending of light at a curved surface. So our eyes are curved. They're little balls. When your vision comes in, you have to take all the light and focus it on one part on the retina so that you can get your full vision. So you see here, here's your focal point, and it's right on the back of the retina. That's where you want it to be. It means you have good vision. Also, this is very important. The image that we see is upside down and reversed. You do the experiment, you have a glass of water, and you put an image behind it, and you look at it through the front, you'll see that the image is flipped and reversed because it's going through water. Same thing with your vision in your eyes. When I'm seeing you upright, really the back of my eye is seeing you flipped and reversed. But then my brain, your primary visual cortex, reverts the image back to normal, and then you can see everything. That's why the little mobiles for like babies are so important, because it keeps them up and looking around. And also looking at people, they know the eyes are on top and the mouth, how we should be oriented. So that's how babies learn with their vision. Okay. So, mechanism of accommodation. Okay, what is accommodating? Changing the shape of the lens to focus on an object. So you guys are now in school. You may be looking at a computer screen more now than you have been ever. Oops, I keep walking into this. Your eyes need to accommodate when you're looking at images that are close to you. It causes eye strain. So there's a 20-20 rule. Every 20 minutes looking at a computer screen, look at something very far away for like 20 seconds. You want your eyes to relax. The only way you can do that is by looking at something far away. You need this muscle to relax. So, ciliary muscle is at the attachment of our suspensory ligaments. Contraction of the ciliary muscle reduces the tension and allows the lens to have a more rounded shape. This is controlled by our parasympathetic nerves. So when we're looking at far distances, do you see how that muscle is relaxed? And the lens is flat and we can look far away. When we're looking at near distance stuff, that ciliary muscle contracts, the lens gets rounder, and you can look at near objects. But again, that ciliary muscle is being contracted the entire time you're looking at something close. So everyone, just when you're studying later tonight, just look far away and just stare blankly at something far away, and you'll feel your eyes like relax a little bit. So that helps with eye strain. So this is under parasympathetic response. You guys got to know this. So ciliary muscle contraction allows you to focus on near objects. When the ciliary muscle relaxes, you can focus on far away stuff. So errors of refraction. Okay, so emmetropia is called, that's normal vision. Myopia is nearsightedness, and so on and so forth. Astigmatism, incorrect curvature of the eye, causing you to have those wavy lines. So if you have astigmatism, you know what I'm talking about. So you can see here, we talked about this focal point. In a normal vision, that point should hit right on the back of the retina. That means the geometry of our lens is correct, so that whatever processing we're getting through the eye projects normally on the back of the eye. If you have myopia, that's where that focal length, that focal point is. It's not in the right spot. That's why you can't see things. So you give a concave corrective lens. It alters the way light goes through your glasses into your eye, and you can see things. This is just how eyes get corrected. You don't have to know this, don't go crazy detail. Just know that the focal point is the important part. And when that is off, it causes your vision to be changed, either with myopia or hyperopia. So here's an example of astigmatism. You know, vertical lines may be blurred, horizontal lines, but that's what astigmatism may look like. Okay, the retina. Retina has pigment epithelium. It's called rhodopsin, and these are in our rods and our cones. You've all heard of rods and cones in our eyes before? Yes?
For the focal point,
Yeah.
that changes
It could be, yeah. And that's why you need glasses. Or your glasses keep changing prescription because that focal point gets worse. So that's why you keep changing. So it's the rhodopsin that allows us to see in like light or dark. We'll go through that in a second. Bipolar cells, we mentioned yesterday or last week about nerves, how they have different properties. In the retina, they have bipolar nerves, which allows for different directions, and you'll see where the ganglion is for that one. Here's the ganglion cell in the output cells of the retina. This is where all the axons collect to become the optic nerve. Remember, this is cranial nerve 2, optic nerve. All these inputs have to go into one nerve, the optic nerve, so that all that can go to the brain where it's got to go. We have horizontal cells and we have amacrine cells, and we'll discuss that as we go through the pictures and whatnot. So here is a way of looking at the retina. Light comes in this way, has to go all the way to the back first, and then it comes forward. And this is a bigger picture of the wall. So here is your receptive field. This is what actually picks up all the light that comes into your eye. Then the signal will travel this way through the rods, through your bipolar cell, into your ganglion cell, and then finally they all collect to go to the optic nerve. That's the pathway of light in our eye. Remember, we have to convert the signal of light to a chemical or electrical signal, and going through all these nerves allows you to get to an electrical signal to go to the brain. So here are some properties of our rods and our cones. Rods are monochromatic, and they help with low light. So rods are just night vision, dark vision, whatever you want to call it, able to see at night better, and so forth. Cones are for color. Okay, we have blue, green, and red. Those are the three colors that our brain can distinguish, and then depending on the intensity of the red, and you start adding in different colors, you get different color changes. But it's all due to the rods and the cones and how much stimulation you get from those colors. Here's an example of how your rods and cones can trick you. Okay, who likes to go to Disney a lot? Especially like Magic Kingdom. What's the color of the concrete everywhere? Orange, reddish color. They do that on purpose because you seeing that red color all the time saturates your red cones so that when you look at the grass is going to be greener to you because you've saturated your red cones. It's a trick they do. They also do a trick with their building colors. They're made to blend in so you don't see them. Next time you go to Disney, just observe things. You'll see it all. Okay? So they trick you into thinking everything's greener because they saturate your reds. So when you're looking at colors, all you're looking at is like a heat map. So if we have like a grid, and here is like your red colors, here's your green, and here's your blue, red may look like this. Not a lot of green, not a lot of blue, but a lot of red. It's going to make up a red color. It's just a heat map. What are you stimulating more of? Which receptors are you stimulating more? That gives you color. Same thing with like taste. We have taste receptors. We'll get to taste in a little bit. For example, you brush your teeth in the morning, it's got a minty flavor. Those mints, that minty flavor has an effect on your tongue, and it occupies certain receptors. What happens when you drink orange juice too fast right after that? It tastes like crap, right? And it hurts. Because you've altered the receptors that are there, so you have a different taste profile because you've already occupied some receptors due to the mint from the toothpaste, so the profile changes. That's why when you're sick, things taste weird as well. You don't have the smell input. So those are our colors. Dark and light adaptation. So yes, I'm glad you can see colors, but how do you do in night and how do you do in dim light and so forth? These are all due to the rods. Remember, this is dark and light, so it's always going to be our rods. In bright light, the rhodopsin dissociates, therefore less visual pigment available, and you can't see. You can't see in dark anymore because as soon as the lights go off, you can't see for a few minutes. In dark light, rhodopsin stores are built up, increasing the phototransduction, and therefore you can see better at night. So anyone know why pirates wear eye patches? It's not because they missed an eye. Yep. So they have one eye covered. So what's going to happen to the rhodopsin stores on the covered eye? They're going to build up because they're dark. It's covered. On the light eye, what's going to happen to the rhodopsin on the eye that's visual to light? Rhodopsin stores go down. But we're on the deck. It's sunny. We have to go down below where it's dark. So when they go down below, they just transfer the patch to the other eye, and their other eye is already ready to go because it's already been used to the dark. They can see what they're doing, go down and do whatever they do, and when they go back up, they switch the patch to the other side, and they can see and they're fine. That's why they wear eye patches. Learned that at St. Augustine, my son's field trip last year. So use it here. Yeah?
Why does vision look like, if you're in a really dark room, why does it look more grainy?
Just because we can't make out details.
Okay.
So rods are always for dark and light vision. Vitamin A, I joke around and say it's carrots, help you with your eye vision, but it's really just vitamin A that helps with the eyes. Just remember, vitamin A is good for your eyes. So for color vision, again, we talked about it already, the pattern of activation tells you what color that you're seeing, depending on how many cones are activated and so forth. And then here's what people see when they have different types of vision problems. So you see these videos of people, they've got those chromatic glasses that they wear them and they can see colors now. What those are doing is they're providing different lenses to allow different lights to get into their eye and they can see things again, the colors at least. So again, that's just for your own fun. Just look at it whatever you want. Okay, visual pathways. So we have the cornea, we have the lens, and we have the retina. When you have the cornea, this is the way light travels. So light goes from the anterior chamber through the pupil into the posterior chamber, and then we get to the lens. Once we get to the lens, light travels through the posterior cavity and it lands on the retina. Once we get to the retina, we have photoreceptors, the rods and cones. Remember, they're going to convert the light signal to an electrical one. So we have our pigmented cells, our rods and cones. Those are the photoreceptors. Then it goes to horizontal cell, bipolar, amacrine, your ganglion, and finally they all converge into the optic nerve. That's how light gets to the optic nerve. So just make sure you know that pathway. It's just anatomy. Just know the direction in which light goes in. So now, how do we get that image, that signal through the optic nerve? Where does it go from the brain to get to where does it got to go? Where's all this information about vision? Where does it have to get to? The posterior visual cortex or whatever it goes. Okay, and it's in the occipital lobe, okay? So axons, they're going to split up depending on what's going on. Eventually, we're going to get to our optic radiation, which is in the back of the brain. So this just kind of explains what we're going to talk about right now. Now, with this one, we're only going to worry about the right side. This part right here. Okay, we're going to go step by step. Okay. You want to do this first or take a break? Break? Okay, come back at 3:25, then we'll start this. Okay, so let's go through this visual pathway. So remember, whenever you are looking at medical images, it's always if you're looking at it from anatomical perspective. So this is the right, and that's the left. So anatomical positions like this, so if I'm standing on that board, my right side, my left side, okay? So we have our vision. And all we're going to worry about is visual fields. And let me just go to a different color here. Yeah.
On your,
I know it's opposite.
yeah.
Don't worry about it. It's fine. They all follow the same thing, whether it's right or left. Pathways are the same. So we have our lateral vision, and we have our medial, which is on the inside, or it's also called nasal. So it's our medial. Okay, your nose is always visible. Our brain just gets rid of it. So if you close one eye, your nose pops up again. But if you keep them both open, the nose goes away. But the nose is in your vision all the time. So we have our medial, which is right in the middle, and we have our lateral, which is on the outside. So she's in my lateral view right now. Not picking on you, you're just there. So that's lateral, medial is right in front of you. So let's color code these and see where they go. So our lateral vision. Remember, when you get to the eye, what happens to the image? It's flipped and reversed. So our lateral vision is going to project on what part of that eye? The medial part, because it's flipped and reversed. So lateral goes to the lateral area. And let me change this to blue for the other side. Okay? So there is our, why is that an arrow? Okay. So that's that one. Medial view. Remember, medial is now going to be lateral because it's flipped and reversed. So let me go, here's the blue. Medial. It's going to project on that. Actually, no, hold on, that's wrong. Medial goes here. And then on this medial goes to that end. Okay, everyone good so far? We have our medial vision on the left, projects on the right eye. The medial vision on the right projects on the left lateral, I'm sorry. So medials go to lateral. Lateral vision goes to the medial retina. In your question on your exam, what you're going to get, make sure you read where I say the vision is starting. Where's the visual field? Not the retinal field. The visual field, the medial visual, will project onto the lateral retina. The lateral field will project onto the medial retina. Okay? Now, once we're here, we have to keep these nerves moving. And they have to go to certain areas of the brain. So, the lateral ones, back in blue, okay, this goes to the lateral geniculate nucleus. Okay. That's where vision goes, to the lateral geniculate nucleus in the hypothalamus, in the thalamus. Remember, all sensory pathways have to go through the thalamus. So this structure, this lateral geniculate nucleus, is part of the thalamus that this nerves travel through. So whenever you see lateral geniculate nucleus, it's always going to be vision. Okay. And now we have our vision from the left lateral. Now this one is going to cross over and go to that lateral geniculate nucleus. This piece right in the middle is called the optic chiasm. Right on top of that optic chiasm sits your pituitary gland. So some people, when they have pituitary adenomas, they have cancer of the pituitary gland. Pituitary gland gets bigger and bigger, and it presses on this optic chiasm, and you get vision changes because this vision is being altered from the optic chiasm. So that's talking about just getting your lateral view. And vision from the left going to the right side. You see here, medial comes down and then all the way down to that part. This is going to go away in a second. Here. Lateral vision on the left projects onto the medial portion, goes through the optic chiasm, and goes to the lateral geniculate nucleus. Now the opposite. We have our medial vision coming from the left onto this one. And this one will then follow that view. So the medial vision, the medial visual field always goes directly to the lateral geniculate nucleus. The lateral field vision, okay, always goes, the lateral geniculate nucleus. Now, the medial vision is going to go through the optic chiasm and eventually get there. Again, this is still the lateral geniculate nucleus. Obviously, we have two sides, left and right, so we have to get them both there. Okay? Now, we're at the lateral geniculate nucleus. All the vision has got there. So, from the lateral geniculate nucleus, they go right here, and then the other one will do it as well. Okay? And remember, in the back, primary visual cortex, and then our brain will process the image, reverse it, flip it, and we can see things upright again. So this occipital lobe, people get concussions, they fall back and they hit their head, the back of their head on a hard surface. Well, what structure are you compounding when you hit it that hard on the back of the head? Your primary visual cortex. That's why some people will see stars, or their vision gets blurry and goes away when they hit their head really hard. Because you're disrupting your occipital lobe, which is where your primary visual cortex is, and it will alter your vision. Okay? Any questions about the pathways? So, let's do one more step here. So, what visual field goes to the optic chiasm? Lateral. So, if my optic chiasm is now damaged, we know both lateral fields go through the optic chiasm. Will I lose that lateral vision? Yes, it's called bitemporal hemianopsia. Basically, it's tunnel vision. All I can see is a tunnel, my medial vision. Why? Because the medial vision goes directly to the lateral geniculate nucleus. It does not cross the optic chiasm. Your lateral visual fields go through the optic chiasm. Your medial vision, which was projected on the lateral retina, goes through the optic chiasm. If you cut that signal, your lateral vision goes away because you got rid of that nerve. So all you have is tunnel vision. You can't see lateral. That's a consequence of that optic chiasm. Okay. Eye movements. I'm not going to go through this. Just remember this part. LR6, SO4, R3. Your lateral rectus is controlled by cranial nerve 6. Superior oblique is controlled by cranial nerve 4. And all the rest of them are controlled by cranial nerve 3. That's an easy way to remember your eye movements. LR6, SO4, R3. Okay? That's all I want you to know from my class anyway. Okay, autonomic innervation of the eye. We have motor and you have visceral. Okay, obviously we have to move our eyes, so we need some motor input so we can move our eyes. And we have the visceral part, which has to deal with parasympathetic fibers, which pass into cranial nerve 3, which is our oculomotor nerve, right? Keeps things moving. We're going to talk about here with this autonomic innervation of the eye is our pupillary response. And we'll see how different systems cause different reflexes. Okay, so pupillary reflex. PAs yesterday or this morning, you guys were doing the eye exam with the flashlight. Okay, AA, you still have to examine a patient before you induce them. You want to make sure that they're doing okay. So you still have to know what's going on. So, meiosis, which is constriction of the pupil in bright light, is a parasympathetic response. Okay, so if you're on a drug that mimics a parasympathetic drug, like acetylcholine, we give a parasympathetic stimulant, what do you think their eyes are going to do? They're going to constrict because you're giving them a parasympathetic drug. Okay? And the parasympathetic innervation constricts the circular muscles. And as they constrict, it just makes like a tight spiral, like an iris. If you have a camera and you have that little lens that's built in, and as you slide it, the whole thing moves and slides to close the iris, the camera. Same thing, our pupils. The constriction of the circular muscle causes pupils to constrict, and that's under parasympathetic innervation. Sympathetic stimulation causes the radial muscles to contract, and that causes your pupil to dilate. So it causes mydriasis, or dilation of the eye. And that's a sympathetic response. Okay? Drug overdoses, like cocaine. Cocaine is a sympathomimetic drug. It's going to stimulate the sympathetic nervous system. That's why people with cocaine, they come in and their pupils are like saucers. They're wide open because of the cocaine stimulating the sympathetic nervous system, causing the eyes to dilate. And the muscle that does it is the radial muscle. So you have to know, parasympathetic circular muscle causes constriction. Sympathetic innervation or stimulation on the radial muscle causes dilation of the pupil. So more light can come in. Also, just think sympathetic is always fight or flight. You're going to fight something, you're going to run away. You want your eyes to be bright and open and pupils wide so you can see everything around you to know where you have to go. So that's kind of like the evolutionary reason why we have our sympathetic system. Okay, any questions about vision? So make sure you understand rods and cones, make sure you understand how rhodopsin works, make sure you know the pathway the light travels, know the pathway from the optic nerve to the primary visual cortex. Remember when you're studying that, lateral field vision or lateral visual field projects onto the medial retina. Lateral vision projects onto the medial side of the retina. Your medial vision projects onto the lateral side of the retina. When you're studying that, keep those words there. Because on a test, I'm going to tell you, visual field is here, where does it go? So it starts with the visual field. Okay, moving on to auditory and vestibular systems. How do we hear in our balance? Okay. Sense of hearing does include complex higher processing that allows you to have verbal communication. So you listening to me asking you a question, your brain will interpret what I'm saying, and then you can formulate a cohesive response depending on certain structures of the brain and make sure they're all working properly. The vestibular system tells us about our position of our head and how we're moving. Acceleration, if you go to like the Universal or Disney, the roller coasters, the movement of accelerating is all picked up by your vestibular system. Both vestibular and hearing uses hair cells to transduce the mechanical force into our action potentials. So that mechanical force of you hearing me, my voice is bouncing off your TMs, causing movement in your inner ear, and you get transduction of that signal. Hair cells are bathed in a fluid-filled sensory organ called the membranous labyrinth, and there's two labyrinths in each ear. We have a cochlear version, which is the auditory part, and you have your otolith organs, semicircular canals, and that is your balance. Okay? Okay, so here's just a picture of your ear, and obviously we're going to be focusing on this part. Okay, sound travels at a constant speed through air. The variable properties are either frequency or the amplitude. Okay, I know some of you are young, you don't know, but your car stereo has a radio function. So FM is your frequency modulation. AM is amplitude modulation. That's where FM and AM come from. If you ever listen to AM radio and you're traveling through mountains and hills, you can't hear it because they can't get over the mountains. That's why you go through valleys, you lose signal because of the way radio frequencies are. So same thing with hearing. Either a frequency goes up or the amplitude, the volume or the frequency which goes up. So frequency determines the pitch, is it high or low tone, and then the amplitude is just the intensity of the sound. How loud is it? Okay, outer ear, sounds are funneled through our auricles, and the way your ear is shaped dictates how sound will travel through the ear, and then eventually get to your TM, your eardrum. The middle ear is between your tympanic membrane and the cochlea, has your three bones, malleus, incus, and the stapes. Vibrations are transmitted along those bones. The stapedius muscle is very good because it's like a safety net. It's supposed to dampen the signal if its sounds are too loud. So if you go to like a concert, you don't wear earplugs, and you leave, you feel that weird fuzziness in your ears for a while. Your ears kind of got burnt out from all the stimulus, and then it takes a while for it to reset. But the stapedius muscle is supposed to help out dampen that vibration if it gets too intense. Here's our inner ear. We have these different tubes in here in the cochlea. Again, this is just hearing. We're not doing anything with balance yet. We're just focusing on hearing. We have these three coiled areas, scala vestibuli, media, and tympani. The important thing is this organ of Corti. That is the whole mechanism. This whole thing that I just circled is the organ of Corti. That changes my audio signal into a chemical, electrical one. And it happens at the organ of Corti is where this happens. Okay, so where is that still there? Just give it a second. It's probably going to catch up. Okay. So receptors, organ of Corti, that's where the transduction happens. Sensory hairs on the basilar membrane project into the endolymph of the cochlear duct. This endolymph we're going to talk about a lot. It's unique in the way that it generates action potentials. It converts sound waves into that electrical impulse, and it goes up your vestibulocochlear nerve, cranial nerve 8. So when sound waves enter the scala media, membrane vibrates and it bends the stereocilia. That bending of the stereocilia is what promotes the transduction of the mechanical wave to the chemical one. So it's the bending of the stereocilia. And we'll talk about that in a second here. So fluids in the ear. This is very important. Perilymph and endolymph, just think of these as intracellular versus extracellular. They're just parts of the ear. It's not really in a cell or out of a cell, But when we set it up that way, you'll see that the potassium is different in the ear. The perilymph, similar to our extracellular fluid, low potassium, high sodium. And this fills the scala vestibuli and the tympani. The endolymph, very high potassium and low sodium. This has become important because it's the movement of this potassium that causes the action potential in the ear. What causes the action potential in every other part of the body? Movement of what? Sodium. In the ear, it's not sodium that moves, it's potassium. I don't know why, what the reason for it is, but in the ear, for you to transcode that signal, it's got to be potassium that moves, not sodium. So here is our transduction of sound. Here is a kinocilium, and you notice how the hairs decrease in size. As sound goes in, it bends the stereocilia, which is all these little ones, to the kinocilium. You bend the hairs towards the kino, which is the bigger one. Okay, as that bends and these things start to move towards the kinocilium, it causes potassium to go into the cell. Whereas normally it would be sodium, but in the ear it's potassium that causes the movement. It's still going into the cell, but remember in every other cell in our body, potassium is leaving the cell. It's flipped in the ear. Potassium channels open up that are facing the endolymph. Potassium rushes in, depolarizing the cell, and the potassium returns to the perilymph at the base of the stereocilia. So it's the hair, those little hair cells moving that provides the influx of potassium, causing the depolarization. Here's your calcium for all those neurotransmitters in the vesicles. Vesicles go to the end, go into the presynaptic membrane, and they depolarize your auditory nerve so you can hear things. So when you ever hear people say, oh, you got to protect your hair cells in your ear because that's how you go deaf, that's what we're talking about. These are the hair cells that bend and they move towards the kinocilium to cause depolarization, and that stimulates the nerve. So we have inner and outer hair cells. The inner ones transduce sound to the neurites from the auditory nerve, and the outer hair cells are the amplifier. If you damage those outer hair cells, you cause deafness. So it's the outer hair cells causing deafness. The inner hair cells don't, and they're a little more protected from where they are in the ear. So for hearing, again, potassium movement, flux causes depolarization in the ear. So ototoxicity, problem with hearing. Some of the antibiotics that we give can cause hearing problems. Bless you. So if someone comes in, I started on this antibiotic last week, now I'm having hearing issues, it might be the antibiotic. Just stop the antibiotic and the hearing hopefully comes back. So that's the only thing you have to worry about for hearing. Now is the balance part. Okay, balance and equilibrium controls eye movement and body posture. Okay, you guys ever go on those simulation rides like Spider-Man or the other ones at the Universal and Disney? Well, what are your inputs coming in? You have visual, because you're looking at what's going on. You have vestibular, because what you're in is moving, right? And then you also have feedback from the muscles. We'll get to that in a second. Our posture. So if we're looking one way or the other, we have to know which way we're moving so we don't get off balance and dizzy. On those simulation rides, if one aspect of that is off, if the sound is off, if the movement of that little vehicle that you're in is off, you're puking everywhere because your equilibrium is totally thrown off because you're getting input from different areas for balance. So as we go through this section, you can see how our balance is altered depending on which direction that we're in. So again, vestibular dysfunction manifests uncontrolled eye movements, feeling of nausea, and vertigo. So vertigo is just feeling dizzy all the time. We have two structures that provide sensation. We have the otolith organs, and we have our semicircular canals. Okay? Otoliths, they have two forms, a utricle and a saccule. Those are the only two structures. All they detect are tilting of the head and linear acceleration. Am I going fast forward? The utricle and the saccule will tell you that. Am I going backwards, like you're in your car and you zoom out to get away from the school? That acceleration that you're feeling is being picked up by the utricle and the saccule, depending on what direction you're going in. That's how we know if we're going forwards or backwards. You have to know position, where you are. Are we going forward in a car or are we going backward in a car? The way that these things bend and depolarize will tell you which way you're going. We also have our semicircular canals, and those are angular movements. So the otoliths, just forward and back. But the semicircular canals will tell you everything else. And we'll go through that in a second. So utricles are for horizontal movement, and your saccules are for vertical. So if you go on those rides where you're sitting in a chair and it just goes straight up in the air, when you go straight up in the air, your saccule will tell you what direction you're going in. If I'm in a car and I hit the gas pedal real fast, I just take off, but I'm going forward on a straight level, that is the utricle because of the way that it's set up and positioned that way. Okay? Everyone good so far in these two things? Okay? This is where we have that gel, and sometimes you can get otolith stones in here. And that where you get like off balance, you have to kind of go through a different procedure to kind of move your head around different areas to get that little stone out. So, again, we're in the ear with the endolymph and the perilymph, so we're talking about potassium movement. So everything with the ear is always potassium causing the depolarization, not sodium. Only in the ear. Everything else is going to be sodium. So we still have our kinocilium, which is that one really, really big one. And we have the stereocilia, which are the smaller ones next to it. In the ear, when we're listening to things, so for the auditory version, when I'm speaking to you, the stereocilia bend towards the kinocilium, causing potassium to rush in and everything to happen, which is fine for balance and for hearing. But for balance, if you see here, the stereocilia are bending towards the kinocilium. You guys see on the right how it's bending towards it? That's going to cause depolarization, causing activation, and it causes an increased discharge. Again, position sense. You have to know, are you going, what direction are you going in versus the other? So if we're depolarizing the cell, the stereocilia bend towards the kinocilium, you get a depolarization, which is still an action, right? You're still getting something happening, which is depolarization. If the kinocilia now bends towards the stereocilia, now we're going the opposite direction, and we get deactivation, which is still an input to the brain. Okay, if I'm going forward with my utricle and your saccule, and they're bending a certain direction, I know I'm going forward. If I'm going backwards, now they're going to bend the opposite direction, so I'm going backwards. It's going to tell my brain that I'm walking backwards. I have a backwards acceleration. I'm walking forwards now. All that gel in your perilymph and the endolymph is going to bend the stereocilia towards the kinocilium, and now I know I'm going forward. So depending on how it's bending, will tell you directions. They can be like on or off. And so here's another example, okay? She's looking down. The gel moves down and it forces all those hairs to bend in that direction, and your brain will correct that input and notice that we're bending our head down. And that's kind of how our balance works in that way. So that's just looking at acceleration, forward and backwards, up and down. But we travel in angles and we do different weird things, so we have to know our position sense that way. So in our semicircular canals, we have a cupula. And in that cupula is our whole system there. That whole kinocilium, stereocilia, they're all right there in that structure called the cupula. Our superior canal is nodding your head. So that my superior canal is moving. They're being depolarized more frequently than the other ones, and we know that my head is nodding my head up and down. Horizontal canal is shaking your head left and right. So my horizontal canal is moving back and forth, and that gives you the sensation that I'm moving my head back and forth. The last canal is our posterior canal, and that's our rotation of plane from left to right shoulder like this. Okay? That's what the horizontal one, or posterior one does. I'm not going to ask you which one does what. Just know what they do. So don't go crazy studying that stuff. So here's the whole thing where we kind of put everything together. Where I was talking about those simulation rides, how if anything is off, you're going to get up puking everywhere. So we have our vestibular neurons. Here's our cranial nerve 8, and it goes into our brain in our sensory areas. We also get limb motor, neck motor neurons. Which way is our neck turned? Does that coordinate with the direction we're looking at? Does that make sense? Extraocular motor neurons. Remember LR6SO4 and R3? They're all right there. How are they being stimulated right now? Are we looking in a certain direction versus another direction? If I'm going in this direction, but I'm looking that way, like, am I going to get off balance that way? You get all this input from different areas, and they all give you a sense of balance. So just know that our balance is, yes, it's our vestibulocochlear nerve, but there are other inputs that also have an effect on our balance. Eyes, motor system, depending on where we're looking, and just think of those simulation rides. So there's just about vertigo. Do that if you want. Gustation and olfaction, so taste and smell. Okay, so taste is gustation, smell is olfaction. Very familiar examples of chemoreception. We're smelling chemicals that bind to a receptor in our nose, and they give us a sense of smell. You're drinking something, you're tasting something, it occupies your receptors on your tongue, and it gives you a sensation of taste. Only 5 basic qualities of taste: sour, sweet, salt, bitter, and umami, which is that Japanese savory flavor, soy and mushrooms and stuff like that. The ability to perceive subtleties of flavor depends on both taste and smell, again, which is why when you're sick and your nose is all blocked up, you can't smell very well. Food tastes weird because you can't smell it, and they both kind of go together to give you the sensation of taste, which is why you go to like Chili's and you see like, or you smell the fajitas walking around, you get hungry, your mouth starts salivating because you're smelling it, it's triggering you to eat. So here are the receptors for our taste receptors. We have the little taste pores, and again, all you're doing is you have pores for different things, and they all have different receptors, and that was what gives you taste. Now, what do they connect to? Salt, obviously, will use sodium channels to sense sodium in the mouth. Very easy. So the food has sodium in it. We taste salty, we'll know it's there. Sourness is a response to acidity, therefore senses hydrogen. Okay, anyone have any Sour Patch Kids on you? Okay, what's the ingredient in Sour Patch Kids that make them sour? Citric acid or acetic acid. Those are acids. Okay, lemon, sour, a lot of acidity, hydrogen. Okay, sweetness uses intracellular second messengers, and we'll talk more about that in chapter 8. What was the thing I told you about secondary messengers, like those G proteins? What's their purpose? Amplification. They amplify the signal. Bitterness, we have more than one transduction mechanism, but the majority is potassium and their secondary messengers. So bitterness is potassium. We are very sensitive to bitterness. Why bitterness? What is that associated with usually? Poisons. Okay, we don't like bitter. If you're a person that can't eat cilantro because it tastes bitter to you, that's a genetic defect. Some people eat cilantro, it tastes fine. Some people, it tastes like garbage. It's a genetic thing based off your taste receptors. But bitterness is potassium. Umami, okay, amino acids, particularly your glutamate. So your monosodium glutamate, just think of that as umami. Okay, remember, what is glutamate? Excitatory neurotransmitter in the brain. What is the most common inhibitory neurotransmitter in the brain? GABA, very good. So that is basically what we taste in our food, and depending on what the concentration is, again, that heat map, what are you triggering more of is what you'll get in that flavor profile. Okay. So all you have to know for this one, again, the facial nerve, first 2/3 of the tongue, so all this right here, it goes on the facial nerve. And obviously it's going to go through the thalamus. Remember, all sensory has to go through the thalamus. Taste is a sense. So it's got to go through the thalamus, and then it goes wherever it's got to go, to the tongue, part of the homunculus. We're not going to get in that much detail. Just know that the anterior 2/3 of the tongue is sensed by the facial nerve, and the posterior third is glossopharyngeal. Salivation, we have salivary glands. Okay, sublingual gland is your facial, submandible is facial, but then your parotid glands is the only one that's different. So all of our different glands we have that produce salivation. So again, going back to that Chili's example with the fajitas, you smell it, you're thinking your brain that you're going to be eating soon, so you start salivating so you can help with digestion. We'll get to digestion in a few chapters. Swallowing. You don't have to know these cranial nerves, but what is it important to know? That swallowing requires a lot of nerves in order to do that. Anyone that has a stroke or a presumed stroke, you can't have them eat anything because you don't know if any of these cranial nerves have been affected. How are they going to be able to swallow? It's a very precise, coordinated movement to swallow until they tell you to swallow. Then you can't do it, right? Like, you guys start checking your thyroid yet in PD? You say swallow, and you can't do it. That's what I'm talking about. Until they tell you to swallow, and you can't. Olfactory receptors, our smell. Okay? This is like one of the only parts of our brain that are exposed to the outside environment. It's from the nose. Okay, we have these olfactory receptors, and when they get activated by a certain smell, which is a molecule, it's going to bind to a receptor, and it's going to tell you what to do, or give you a sensation of smell. Don't go crazy with this one. Again, just keep it simple. The odorant, which is the chemical, comes into the nose, you breathe it in, and we have receptors that do all that. We've lost a lot of our sense of smell because we don't really need it as much anymore. Like animals obviously still have heightened smell. If you have a dog, they sniff everything. That's how they get their input. We don't go around sniffing butts anymore because we've evolved and we don't need our nose that much anymore. If you want a nice little hack to your brain for studying, when you're studying different topics, use different scents. Like your essential oils that everyone loves, which are essential to nothing. It's the essence of the plant is that's why you call it essential oil. It's the essence of, basically it's like vanilla extract. That's what essential oils are. It's the essence of the smell. Anyway, if you use a different scent for each class and you're studying while that scent is going on, the morning of the exam, smell that scent like crazy. It'll bring all your memories back. You ever notice when you smell certain things, it brings back memories of whatever you were doing when you smelled that? Same thing with smell, with the studying. No one ever does it. I tell everyone the first week of the school, 2 weeks, like, you can hack it, but no one ever does it. So if you do it, let me know. So here is our odorant receptors. Here's all of our our receptor. Again, it's a secondary messenger protein, so we know it's going to amplify the signal. That's why a little bit of a smell has a bigger sensation to the brain, because it's a small little bit. You don't need much. It's a secondary messenger. It's going to amplify that signal. Still uses calcium to come in. Let's look at this one more time, because I want you to look at this part. Why is that important where those chloride channels are? Look at this neuron. Why is that important? It's inhibitory. Remember, the calcium and sodium coming in is going to be stimulatory. excitatory. But remember, we mentioned last week in class, the way that our neurons are set up is that the inhibitory portion blocks anything prior from getting into the brain. Here is the inhibitory portion. So anything excitatory below it, it can still stop that signal from going up. So this is an example, only because the chloride channels are there. I wanted to reinforce that concept from last week. We have the inhibitory neurons closest to the cell body to stop any stimuli from happening. It's a control mechanism to keep things quiet so they don't go out of whack. So that's smell. So taste and smell kind of go together. Obviously, as you're eating something, the smell is going to go into your nose. Drinking something, you're going to smell it as well. They kind of go together. And obviously, olfaction greatly influences your taste. So taste and smell kind of go together. You have your tongue input, and they're obviously going to go to your thalamus because that's where all sensory goes. So that's smell and taste. Any questions about tasting and smelling things? Okay. What time is it? 4:08. Okay, we're going to stop here. Tomorrow, we're going to finish this up and start immunity. And whatever we don't finish, we'll finish on Thursday for the review. But tomorrow, we'll have class at 12:30 tomorrow. So I'll switch it in your calendars tonight, but tomorrow, well, you'll be here anyway, but 12:30 will be phys tomorrow. One last thing, guys. If you're studying, this is whether it's my class or any other class, if you're stuck on a concept and you just can't get it, just move on and come find me or your teacher. Taking 2 minutes with me will solve half an hour of your work. Okay, so just come find me if you have questions, your other teachers as well. See you guys tomorrow.